I don't see that ocular melanoma is different from any other cancer in that respect, and I think it should be treated the same, and I think you need biopsies because you need to know what the risk is. You can look at size of tumours, depth of tumours, you can look at other features, but having a prognostic index tells you how much you've got to throw at that patient, because as well I think we are just at the point where we're starting to see potential for new treatments to come through that may actually be useful in an adjuvant setting, which is giving something, or neoadjuvant setting, which is giving something preemptively. I'm going to talk about the role of Delcath, Chemosat, PHP in ocular melanoma. I don't think Delcath are quite sure whether this is called Delcath, called Chemosat, or called PHP, or a combination of the three. It seems to be different things in different parts of the world. I don't actually do this myself. We have interventional radiologists who do all the clever stuff. But fortunately, I've nicked a whole load of their slides, and I've learned a whole load in the process. So, although the talk has all been about Delcath in the last year or two, the bench work started in 2001, and they had a phase 1 study, which I'll talk about a bit more, in 2005. It's really been an extension of an old technique, which is trying to infuse the liver with chemo. And I'll show you some slides on what that was about. The current European Union device indication is it's for percutaneous, i.e. across the skin, intra-arterial, so into the blood vessels, administration of chemotherapy agents, specifically melphalan at the moment, but they are looking at other agents, to fill the liver with chemo agent, and then using extracorporeal filtration, they suck it out and give the blood a wash, filter out the poisons and put it back in. So the rationale for looking at a whole organ therapy in the liver is the liver is sat on this very big tube, the inferior vena cava, which takes all the blood from the lower half of your body back to the heart. And it's got two sets of blood vessels going in. It's got arteries going in as well as the portal veins. And because of this vascular anatomy, it means that there is the option of isolating the liver and then treating it as a single organ. The majority of tumours, secondary tumours and primary tumours in the liver, get their blood supply from the arteries rather than the veins. So that means that if you can infuse poisons, toxins, chemotherapy into the arteries, they selectively damage tumours more than the normal liver background tissue. Now, if you can also isolate the liver, then you can just treat the liver as a whole and give doses that other parts of your body might not be able to tolerate. If you look at the intraoperative hepatic perfusion that used to be done, what that used to involve was a big open operation, split from stem to stern, with clamps on all the blood vessels around the liver, and then cannulation of the arteries and pouring chemo in and washing it out again. And that's a one-off treatment. You can only do that during an operation. It's very, very invasive. It had some encouraging results, but at the end of the day, because of the magnitude of the insult, it's not something that can be readily dished out on a frequent basis. But essentially that gave encouragement from the few specialist centres that were doing it, such as MD Anderson. But it's a big hit. It's 6 to 8 hours in theatre, 2 or 3 days in ITU, 10 days in hospital, and most patients just aren't up for that kind of level of insult if it's not something that's going to give you a high chance of a cure. So chemosaturation, what that does is it tries to achieve the same percutaneously, i.e. going through the skin up into the blood vessels, and basically you end up with catheters, which are fine pipes placed across the heart and into the inferior vena cava, and balloons blown up inside the blood vessels. So rather than clamps on the outside, the balloons are on the inside, isolating the venous return from the liver. And then using, again, percutaneous techniques, you feed a fine catheter up through the arterial system from the groin, all the way up into the arteries, into the liver, and then you can release the chemo in there. So it's all quite high-tech stuff. You also have to take the blood that's out, that's coming out, and you filter that extracorporeally, i.e. outside the body, filter out the chemo agents and put it back in. So it's a big procedure to have done. And it's just another schematic looking at the filtration procedure itself. And again, there's a lot of kit, and it's taken a lot of development. And the box that comes with this lot in, the box on its own costs £15,000 at the moment. So that's a big outlay. The little picture on the top right is really the kind of the smart idea, the key thing. It's the balloons blown up either side of this catheter with a filtration, a kind of suction end that you can suck the blood back through out of that. And it's a very technical procedure, and it has these potential advantages and features. Essentially, it's a whole organ therapy. So not only are you treating visible tumours, so as a surgeon I can only treat what I can see, but this, because it soaks the whole organ in chemo, has the potential advantage that it treats microscopic disease that hasn't yet developed into visible secondary deposits. Because of the isolation of the liver, you get this very high concentration of the chemo, and you get to higher levels and higher kill levels for the tumour cells. And you have the advantage with this of the filtration, meaning that as you clear the drug out, you don't actually get the same levels of toxicity that you might from the drugs if they were just washing around your circulation. The European Union indications for Delcath ChemoSat, it's been approved by the EU for percutaneous administration of chemo to the liver with filtration and, as described, lowering the concentration of the chemotherapy agents in the blood. Melphalan is a really ancient chemotherapy agent. I'm not an oncologist, so I'm not going to try and tell you about all the important bits on this, but my understanding is it's been around for 50 years, the best part thereof, and it's one of the kind of original mainstay agents. So it's very well understood. One thing about it is it doesn't do much damage to the liver, so you can put an enormous amount into the liver just as long as you can get it out without it getting into the bone marrow, because it is very damaging to bone marrow. And it's often specifically used for bone marrow tumours, specifically a condition called multiple myeloma. It's also used for some brain tumours in children and ovarian cancer. And occasionally it's used for perfusion of sarcomas, which are tumours that can affect limbs and extremities. Now, if you look at the kind of tumours that are sensitive to melphalan, the bottom left-hand side of that, third one along, it says melanoma. And the lower the bar is, the more sensitive the tumour is to this particular drug. So melphalan actually is pretty good for melanoma, and that's one of the reasons that it's been extensively investigated in melanoma in the original trials. Cancer drug trials come in different phases. A phase 1 trial is basically, it's just an early trial run of a cancer drug, often in fewer than 30 patients, to try and establish safe doses. It's very early stuff. It's looking at side effects and possible benefits. I'm going to talk about a phase 1 study and also a phase 3 study. Phase 3 is moving a lot further on, and usually a randomized trial, and it's comparing the new treatment with established treatment or best available care. So what have we got to give us information with regards to ChemoSat and melphalan? So first of all, they looked at the dosage that they were going to be able to apply, and the dosage that they came out with was 10 times higher than the dose that would be given if you were giving it intravenously. Because it's given arterially into the tumours in the liver, you actually end up with something like 100 times the dose that you would get if it was just dripped into your arm, actually effectively getting into the tumours. So it's an intense concentration of the chemo drug. And the initial filters in the phase 1 study removed 3/4 of the drug. So it's a proof of concept, and the results that came out in 2005, they looked at 11 patients, all of whom had ocular melanoma, and they saw that 3 patients had stable disease, which means that on scans nothing changed. 2 patients had disease that grew on subsequent imaging. Partial response means that there's a measurable decrease in the size of the disease. And they also had 2 patients who had what appeared to be a complete response, which is that it doesn't necessarily mean you're cured, but it means that you can no longer see the tumours on scans. So these are all patients with secondary disease isolated to the liver. Okay, so effectively it's looking, this initial study, to give us just evidence that it does work and a safety effect. You need a big team if you're going to go and do this procedure. You need an oncologist, you need an interventional radiologist, you need a perfusionist, who's somebody who manages the pumps and filters as the blood's being circulated outside the body. You need anaesthetists who are familiar with all of the cardiac issues and how to manage people who are effectively on a bypass machine. You need pharmacists to draw up and make the drugs, you need the nursing staff available, you need all the interventional radiology staff, and you need an intensive care and critical care specialist available as well. So there's actually, you need a bigger team for this procedure than you do for somebody who's having a heart bypass operation. It's very, very labour intensive and specialist intensive. So we've been looking, or the initial studies in the States have been looking at surgically unresectable metastatic melanoma, patients over 18 years of age, reasonable body weight, and those patients who've got too much tumour, more than 50%, been not able to be included. You've got to be off chemotherapy or other treatments that might affect the liver for over a month, and must have visibly recovered from any of these things. So you need to also be relatively fit to get into the studies. You need to have decent liver function. So if you've got too much disease and your liver's struggling, it's too late, I'm afraid. You need to have reasonable blood counts. You can't be anemic or short on any of the other factors that help your blood to clot. You've got to have a decent number of platelets. You've got to have decent kidney function. Can't be pregnant. Can't have cirrhosis. Can't have heart failure. You can't have significant lung disease. Again, still can't be pregnant. And you've got to have a decent working immune system. Can't have active sepsis. Can't have severe allergy to anything we might use. Can't react to melphalan. If you know that, then it's a no-brainer, isn't it? If you've got problems with bleeding, can't go in. And there's a rare tumour and an uncommon operation that you can't have had. If you're going to go for the operation, go for the procedure, then you need an up-to-date history and physical exam. You need to have intensive imaging to make sure that this is the only site of disease. You haven't got other things that are going to cause a problem, because you need to have your blood drastically thinned during the procedure whilst you're on the bypass machine and the filtration machine. And if you've got sites that might bleed elsewhere, such as tumours in your head, then that needs to be excluded. Lots of lab workup, lots of checking of hearts and lungs, because this is a huge stress on the body, having half of the return of the blood blocked off whilst the procedure goes on. So right before the procedure, you need everything rechecking again. Sometimes you may need more scans, and you might need a mapping angiogram to look at the blood vessels around the liver. You can often look at that on the CT angiogram, on the CT. So afterwards, patients go to ITU. They need to be intensively monitored, and we need to watch for signs of toxicity, which are signs that the chemo's got into the system and not all been filtered out. So lots of close monitoring in intensive care, and sometimes patients stay in intensive care for 2-3 days and go straight out. More commonly, we're stepping them down onto the ward. So this is a couple of lines looking at the dosage that you get into the circulation, and with the filtration system, you can see the hepatic dose, the yellow block, gets much higher peak levels compared with what's escaping into the circulation. Since a phase 1 study, and I think it was halfway through the phase 2 study, they introduced a new filter, which shows the blue line on top, is that it's 97% efficient at getting rid of the chemo, rather than the original filter, which at best had an average of 91%, but I think in some of their studies dropped lower. One of the problems with this is a picture of the inferior vena cava with a big balloon blocking off the main pipe, but you can see there's some parallel pipes running alongside. Not everybody's anatomy is absolutely typical, and some people have extra venous drainage systems that can open up when they're put under pressure, and so chemotherapy can escape and bypass around the balloons. This is a couple of graphs looking at what happens to the platelets and the white cells, and in the relationship to the procedure. And it's typical for both the platelets and the white cells in your bloodstream to plummet shortly after you've had the procedure. So that's something that needs to be watched for and sometimes needs to be supported. Now, the treatment can be given again and again and again. You can do it up to every 4 to 8 weeks if the tumour's responding and you're not suffering from side effects from the procedure. So how does this fit in? It's not a systemic therapy, so if you've got disease in multiple sites, you're certainly going to need systemic treatment, possibly on top. Is it competing with focal tumour therapies? Well, if you can remove all visible disease or eradicate all visible disease, then it's a question of whether this is something that you would think of, again, on top of that as consolidation treatment, because we know that patients with ocular melanoma seldom just get one deposit in their liver, it tends to recur and recur. So it's a whole organ therapy. Really, it doesn't have any other direct competitors at the moment. This is looking at some of the results from the phase 3 study that came out in 2010. So this is a randomized study, and this is just a quick look at the study design. Basically, it was comparing patients with both cutaneous and ocular melanoma, having either chemosat or best available care as an alternative, which basically could be chemotherapy, it could be ablation, it could be a range of treatments, but they're all patients who are thought not to have curable disease. And according to the treatment protocol, they could get repeatedly treated every 4 or 5 weeks. On average, people got 2.3 cycles. So the first results that came out, one problem with the study design is that if you were in the best available care arm and you had progressive disease, weren't responding to the treatment, you could then cross over to get the chemosat, which really complicates interpretation of the results. The patient groups between those getting PHP versus those getting best available care are directly comparable. The main endpoint that they were looking at was progression-free survival of the liver tumours. So are the liver tumours stable? Are they regressing? Is there no evidence that they're still growing? And that showed a difference for progression-free survival between 1.6 months in best available care versus 8 months in the PHP group. They looked at some other endpoints from this. And this is overall progression-free survival. Now bear in mind that they were also having patients cross over. So it is a slightly complex to unpick some of this, and unfortunately they haven't provided all of the graphs for all of the different groups, which would actually make things particularly easier to interpret. Because basically, this is looking at overall survival. If you were doing badly, you switched into the PHP arm. And so overall, most patients seem to be living about the same length of time. But these are very hard to interpret, because if you were doing well, you stayed in the BAC arm. If you were doing badly, you went into PHP and perhaps dragged down the results from the PHP group, if that makes sense. And this is another review of that. And this is looking at those patients, including the crossover, versus and adding all the crossover patients into the PHP group. And that shows that, again, you got an increased survival up to 11 months versus 4 months overall survival on average. I mean, these are not particularly stunning figures to be hearing bandied around, but this is the worst group that they were picking. So, given these confounding factors with the crossover, I think at the end of the day, you still have to say that there is an improvement in survival, but the confounding factor is that the crossover arm skewed the results and made their reporting difficult to interpret. Looking at other endpoints, you can look at the number of patients who had a complete response. In this, there were none, but there were decent numbers. 15 had a partial response, and then 6 in the crossover arm had a partial response, so actual tumour regression rather than just being stable. There were some treatment-related toxicities, some problems with bone marrow and liver-related failure, and 3 patients died of the treatment. So there were 116 treatments dished out, and 3 patients died related to that. So it's not to be underestimated, as it's got a higher mortality than liver surgery in this study, and it's got a higher mortality than Certex. So you have to bear both of these things in mind. However, they did change from the Mark 1 to the Mark 2 during the course of all this. So looking at the conclusions, it does give you a significant improvement in progression-free survival within the liver. However, the overall survival has been hard to unpick because of the crossover design of the study. There were 3 treatment-related deaths, acceptable liver toxicity, and interestingly, they still have 11 patients in the PHP arm who are still alive a year later after reporting their initial results. So it is making a difference for that group. The question for us is, where is it going to fit into the treatment algorithm? And it's early days, and we really don't know. Is it a curative treatment? I don't think so. Is it a palliative treatment? Yes. Is it something that we might think of giving before other treatments, such as surgery or ablation? We would think about it. It's just very expensive. That's the problem. Would we give it after? Again, we wouldn't mind, but it's very expensive. So hurdles for Delcath, it's not yet got NICE approval in the UK. It's costing, we think, probably about £36,000 for a treatment. And in the States they were dishing them out every 4 to 8 weeks, up to 6 times for some patients. So it's a hellish expensive treatment to justify. You could go to the Cancer Drugs Fund, but it's not a drug. It's melphalan, and it's a device, not a drug. So I don't think they'd fund it. And it's not ever going to be widely available because of the expertise and equipment that are required for it. Patient selection is going to be a big issue, and these are things that we'll have to determine as this evolves. So my conclusions of this, I think it is an effective treatment for liver metastases from ocular melanoma, but it's extremely expensive, and if it's to be rolled out in any way, then we need good evidence in order to generate an NHS-funded funding stream. And costs need to be brought down, because at the end of the day you can buy a new car for the cost of that box of plastic tubes, and I'm sure once they've recouped their development costs, they're in with a shout for bringing that price down. We haven't yet identified the ideal treatment group. And at the moment, we can't say Delcath is superior to either surgery or Certex for treatable disease. We just need to look within those groups and try and pick the specific cases where this might have an advantage for individuals. And at the end of the day, ocular melanoma, when you've got metastases, is a systemic disease. It's not a liver-only disease. Its presentation in a group of patients is with liver-only disease, and it seems to stay that way during their lifetimes. But if we manage to treat the liver exclusively, then I think inevitably the majority of these patients will get other sites of disease outside the liver. So focusing purely on the liver alone is an error. You need to be looking also at another treatment that is going to help patients with their other potential sites of disease. And you need to be looking at conjunction, using these treatments in conjunction, maybe sequentially. And it's how on earth we ever get a study in such a rare tumour to give us those answers. Thank you very much. Another apology, that was a bit techie, wasn't it?
Are there any questions for Neil?
Don't make them techie because I won't know. Sarah?
How long is the actual procedure?
We can do 2 in a day, but as we've only done 3, that's...
So is it 2 to 3 hours?
The setting up time is the big thing. It takes about 1.5 hours to 2 hours to set the patient up. The actual chemo runs for about half an hour, and then there's the kind of gentle reversal of the bypass effects, and so in total time it's about 3 to 4 hours for us at present. I would imagine that as things get slicker, when they've done more of these, the time will be reduced. At the end of the day, we're just trying to do it in an extremely safe environment, not looking for speed. Yeah.
Thanks for the talk. How did you get the funding for the 3 that you've done? Are they self-pay, or have you got
No, Delcath are keen to get this out there, and they're providing the first 6 for free. So there are still 3 slots available, although I think there are 1 or 2 potential takers for them. And we've only got funding for 1 treatment per patient at present. So.
Obviously, Delcath, the system is usable in liver metastasis from other cancers.
Yeah, yeah.
Were all these 3 ocular melanomas, or?
Yeah. We've only been looking at ocular melanoma. Our new procedure group only gave us permission to look at OM at the moment. So we've been through quite a lengthy procedure to administratively get any agreement to start this. But they are looking at primary liver tumours, bowel tumours, and cholangiocarcinoma has been used at. There's also talk of using it for pancreatic metastases. There's an awful lot of potential for it. And I think if they could get into one of the bigger cancer markets rather than just melanoma, then that might mean that they can cut their costs from $15,000 for the box down to $3,000. But it won't get rid of the costs associated with having an interventional theatre suite with all those people in. That runs at about £1,000 an hour for doing that. Going to intensive care costs you £2,500 a day. And if you need various drugs and things to stimulate your blood count, they're hideously expensive. I don't know how much, but I'll say £1,000, but maybe less. But basically, everything about this is expensive. And all the scans, all the PET scans, CTs, MRs, everything you need before, just all adds to the cost. And so we were hoping that the number crunchers in the hospital will get it down to sort of 25, but at the moment, unless we can beat some more money out of them, they reckon it's mid-30s. So we'll see what the final figures come to.
Can we just have one more question from Leslie?
Sorry.
Hi, Leslie.
Hello. So you said 50% people with more than 50% tumour in the liver were excluded.
It's an extreme caution. It means that if more than half of your liver on scans is cancer rather than normal liver, then you probably haven't got enough normal liver to tolerate the procedure well. They have done it in patients with up to about 70% replacement, but with normal liver function. However, as with most of these treatments, like Certex as well, the more bulky tumour you've got, the less effective they are. So you might see stabilisation of disease rather than everything shrinking away, and the less well tolerated it is by the patient.
So what's the ideal?
Small. You're looking at patients with, marbles 1, 2, 3 centimetres, and not patients with 8, 10 centimetre lumps. And that's one reason why we want patients to have tight follow-up. We want to know who to follow up so that we can catch the disease early, because then you make a bigger difference. Okay. Thank you.
Thank you. Thanks very much, Nick.
That's right.
Appreciate
Thanks.
it.